بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we'll continue the discussion of the head and neck infections, and we will go into the other topics. Will include the salivary gland infections. Then we'll proceed with paranasal sinuses and the orbital infections. Then we'll finalize this talk by assessment of cervical lymphadenitis. In acute infection of the salivary glands may be caused by bacterial or viral organisms, and here are the common organisms seen in the clinical practice: the staph, the strep, and the Haemophilus influenza. Silodenitis, whenever it is in the chronic form, it is usually the sequelae of obstruction of the draining duct of the affected salivary gland, and this obstruction may be due to a stricture, calculus, or tumor. And the submandibular gland is frequently involved by infection because of the viscid secretions and the way of drainage of the saliva through this the duct in the mouth floor, and also the frequency of submandibular duct stones compared to other salivary glands. Then the infection of the salivary glands may lead to a formation of an abscess within the affected gland, may lead to a spread of infection through the bloodstream, may affect the adjacent bones, especially the mandible, may also involve the cranial nerves, especially the seventh cranial nerve in cases of parotid silodenitis, and may also be associated with some respiratory complications. And here you can see an inflammatory process involving the left submandibular salivary gland. The gland is considerably enlarged. It shows a heterogeneous CT density and enhancement with multiple internal marginally enhancing loculi representing intraglandular abscesses. Then when you look carefully along the course of the submandibular duct, and then you can easily appreciate the presence of a radio-opaque stone here, which is in most of the cases the cause of obstruction and infection as well. And this is the coronal image, and you can see very well the markedly enlarged submandibular salivary gland, heterogeneous density, intraglandular abscesses, and of course you remember the stranding of the subcutaneous fat, which is one of the findings that can support the possibility that you are dealing with an inflammatory process. And here is another example of submandibular silodenitis due to calculus. The calculus is present in this example at the proximal part of the duct, and consequently the gland is a little bit enlarged, and it also shows a strong homogeneous enhancement. And the differential diagnosis of swelling in the submandibular region will include, of course, submandibular lymph nodes, which are frequently mistaken for submandibular gland itself. Also, mandibular osteomyelitis, submandibular tumors, and submandibular metastatic deposits. This is an example of acute suppurative inflammation of the right parotid gland, The gland is markedly enlarged and it is heterogeneously enhanced with multiple loculi which are marginally enhanced compared to the normal left parotid gland. If you look carefully, you will appreciate the stranding of the subcutaneous fat at the affected site. Then this is acute parotitis with intraparotid abscesses. All these loculi that are marginally enhancing of fluid density may represent the uh, intraparotid abscesses. Also, you can see very well the stranding of the subcutaneous fat. And this process involves both the superficial lobe as well as the deep lobe. And this is clearly evident in the coronal plane. You see the superficial part is affected and the deep part, which is intimately related to the parapharyngeal fat, is also involved. And here a big calculus along the course of the main parotid duct, and consequently the parotid gland is enlarged and is heterogeneously enhanced with marginally enhancing internal loculi of pus and the frequent finding, which is the stranding or smudging or reticulation of the subcutaneous fat related to the involved gland. And this is also an example of right submandibular sialadenitis secondary to a stone obstructing the duct of the submandibular salivary gland. This is the duct which is considerably dilated, and this is the gland which is involved by inflammation. And you can see that the surrounding fat planes are almost obliterated compared to the normal right left submandibular salivary gland. Then this is the obstructing stone. One of the complications of parotitis or inflammation of the salivary gland is the formation of an abscess, and this is a big abscess in the superficial part of the right parotid gland, showing fluid density and marginal enhancement. And sometimes, of course, you can see internal air loculi. And this is also another example of a left parotid abscess. The parotid gland is enlarged. There is a fluid-containing lesion that is marginally enhanced within the superficial lobe of the parotid gland, and you can appreciate the stranding of the subcutaneous fat. And this is submandibular abscess. You see the submandibular salivary gland is markedly enlarged with multiple marginally enhanced cystic hypodense loculi of pus collections. Then if you trace for the cause, and you can appreciate the presence of two radiopaque calculi along the course of the submandibular duct. You know that inflammation of the gland may spread to involve the floor of the mouth, and we have discussed this before. And this inflammation may affect the airway and with obliteration of the fat planes in the mouth floor. And here you can see an example of this. And this is a small abscess in the superficial lobe of the right parotid gland. You see the marginal enhancement, then you see the stranding of the related fat planes, and you also can appreciate the presence of this very small air loculus in the uh, abscess itself. And sometimes you cannot see an obstructing stone and you cannot see a lesion, then you know that infection may be due to hematogenous spread of the organism itself. And hydatid disease is rare in the in the neck, but sometimes it is seen in the clinical practice. And many times this hydatid disease is usually secondary to the presence of hydatid disease in the liver or in the lung. Similar to any hydatid cyst located anywhere in the body, it is a well-defined lesion of appreciable wall thickness with clear water content. Sometimes you can see calcium in the wall. Sometimes you can see floating shadows within the cyst itself representing the endocyst, and sometimes you can see small daughter cysts arranged along the inner aspect of the wall of the hydatid cyst. Then it is well known in the literature that even in endemic areas, hydatid cyst of the cervical region or the craniofacial area is considered extremely rare. The complications are the same as any hydatid cyst anywhere in the body, including rupture, secondary infection, and immunologic reactions. And this is a cystic lesion which is located in the superficial lobe of the right parotid gland. You may say that this is a simple cyst, and also you may appreciate some enhancement of the wall and they say this is an abscess. And one of the rare diagnoses here is the hydatid cyst. And this is stated in the literature that the primary hydatid cyst of the parotid gland is considered extremely rare. And this is another example of a lesion that has been proved to be a hydatid cyst. And this cyst is located in the parapharyngeal area. And you see this tongue-like projection leading to the neural foramen, which at that time raised the possibility of being a cystic schwannoma, for example, but this lesion was proved to be a hydatid cyst. We came to an important issue which is known as Lemierre syndrome, and this is an inflammatory thrombosis of the internal jugular vein. And you see, this is the region of the carotid sheath. These are the internal and external carotid arteries, and this is the internal jugular vein, which is the seat of a small hypodense interluminal thrombus. And this septic thrombosis of the internal jugular vein may follow any primary infection in the surrounding area, including the oral cavity and the pharynx. One of the dangerous complications of this disease is the ability to send the septic emboli, especially to the lung. Then this septic emboli may reach in any organ, but commonly you can see it in the lung. This disease affects healthy adolescent and young adults. Then the causative organism in the majority of cases is the Fusobacterium necrophorum. And this organism can lead to thrombosis of the internal jugular vein and is also present in the emboli or the showers coming from this thrombus. Then the diagnosis will depend on the blood culture and the imaging findings. The treatment will be by antibiotics and the drainage of the infected collections if present in the neck. The use of the anticoagulants in this particular disease is debated as it may sometimes propagate the spread of infection. The Fusobacterium necrophorum is a gram-negative anaerobic bacteria and is one of the oropharyngeal flora. It is capable of causing infection in healthy individuals. Then the condition may start by a sore throat, which may progress to involvement of the region surrounding the tonsil, then extension to the parapharyngeal space. And they know from the previous lecture that the parapharyngeal abscesses are extremely dangerous because they have the ability to affect the internal jugular vein and also the carotid arteries. Then septic emboli usually go to the lung. In this patient, you see this is the internal jugular vein, which is totally thrombosed, and this is the common carotid artery. In the coronal plane, you see that there is thrombosis of the internal jugular vein, and also you may appreciate that the right submandibular salivary gland is relatively swollen, heterogeneously enhanced, and there may be some inflammatory reaction in the surrounding fat planes compared to the normal submandibular salivary gland, which may be the cause of this septic thrombosis. Then this patient is presenting by mild fever and sore throat for 1 week. He is treated from pharyngitis and is presenting now by neck swelling on the right side, and this hugely dilated internal jugular vein showing no evidence of contrast enhancement, denoting its thrombosis. And this is an example of a septic thrombosis of the internal jugular vein. And you see the vein is totally hypodense, then the wall is enhancing, and this is the carotid artery, of course. And this is an example of a patient, female patient, 26 years old. She had she had frequent attacks of pharyngitis and presented with a painful swelling in the neck. And here you can see that the internal jugular vein, this is the normal vein, and this is the thrombosed one. There, there is a large hypodense thrombus within the lumen. And you can see also some of the inflammatory nodes deep to the sternomastoid muscle. But in the scans of the chest, and you can see multiple nodular shadows within both lung fields, as well as the presence of pleural effusion. And you remember that septic emboli, if they are small, they present as homogeneous nodules of homogeneous density, and whenever they are in the size of 1.5 to 2 centimeters, they start to show central areas of breakdown, since septic emboli are one of the causes of cavitating pulmonary nodules, as you remember. And this is an example of a female 49 years old with acute right-sided neck pain, and she has some fever and chest pain, shortness of breath, nausea, and vomiting. There is a collection in the region of the tonsil, and this collection contains air luculi and is marginally enhancing. Then you see that there is a small track leading from the site of infection to the anatomic site of the internal jugular vein, which is totally obliterated, and you can see the whole course of the internal jugular vein, which is obliterated by this septic thrombus. And this is an example of septic thrombosis of the internal jugular vein by contrast enhanced fat suppressed MR image with few septic emboli, and this one is starting to cavitate, but this one is smaller to cavitate, as you can see. And we proceed for the orbital and paranasal sinus infections, and we discussed some of these issues before, but we would like to have an idea or a summary for what has been said before. And periorbital cellulitis is inflammation of the periorbital soft tissues, including the eyelids. And here you can see it. The diagnosis is evident clinically, but you want to see what is behind this closed eye. And here you see there is inflammation of the soft tissues and along the anterior aspect of the globe, extending more or less laterally, but inside the orbit you can appreciate that there is no extension of the inflammatory process. And this is also an example of preseptal cellulitis involving the eyelids and the preseptal area of the orbit extending along the lateral orbital margin, but the orbital contents are not involved by this inflammation. Need you remember whenever we discussed the issue of orbital cellulitis, and we have said that this is frequently a complication of sinusitis, especially the ethmoidal sinusitis, since the inflammatory process can gain an access into the orbital cavity. And one of the frequent complications is the development of what is known as subperiosteal abscess. And this is an example. You see a collection of pus which is marginally enhancing along the uh, the orbital roof, and you appreciate the ethmoidal sinusitis as well as the maxillary sinusitis. And this is a good example of orbital cellulitis secondary to ethmoid and sphenoid sinusitis. There is extension of the inflammatory process along the medial orbital wall, displacing the medial rectus laterally with inflammatory granulation tissue between the muscle and the ethmoids. The complications of sinusitis, orbital complications of sinusitis may include this orbital cellulitis, the development of subperiosteal and orbital abscesses, and what's very important is the access to the cavernous sinus leading to its thrombosis, and this is a known complication of sinusitis in the sphenoid sinus especially. And here you can see ethmoidal sinusitis and sphenoidal sinusitis on the right side with extension of the inflammatory granulation tissue inside the medial part of the orbit and being inseparable from the medial rectus and also reaching the optic nerve. This is an example of orbital cellulitis secondary to ethmoidal and frontal sinusitis. You see here there is involvement of the lacrimal gland and there is inflammatory granulation tissue in the superior lateral aspect of the orbit with swelling of the eyelid as well. And in the axial image, and you can see some air loculi, and this air is usually trapped between the eyelid and the inflammatory reaction here anterior to the globe. And you remember that we have said something about the orbital pseudotumor, which is an idiopathic inflammatory condition usually involves the extraocular muscles, the orbital fat, and the lacrimal gland. In the lesion is usually unilateral but can be bilateral with acute onset of painful proptosis and sometimes diplopia. In order to diagnose orbital pseudotumor, there are some of the stigmata. The first one is the stranding and what we call dirty intraorbital fat, the swelling of one of the extraocular muscles, and the swelling of the lacrimal gland. And sometimes you can see thickening of the posterior sclera and ill definition of the scleral margin may be seen in these cases. And this is an example of right-sided orbital pseudotumor, there is reticulation of the intraorbital fat, a swelling of one of the muscles, and this is the lateral rectus, a swelling of the lacrimal gland. Then these are, in most of the cases, the components of orbital pseudotumor. Orbital pseudotumor, being an autoimmune process, is maybe associated with other conditions like sarcoid, Wegener's granulomatosis, systemic lupus, polyarteritis nodosa, dermatomyositis, rheumatoid arthritis, sclerosing cholangitis, radial thyroiditis, mediastinal fibrosis, and retroperitoneal fibrosis. This is an example of orbital pseudotumor by MRI T1 weighted images after fat suppression. You see the smudging of the intraorbital fat, the swelling of the lateral rectus, and the involvement of the lacrimal gland as well. And this is an orbital pseudotumor affecting the lacrimal gland as well as the eyelid, which are diffusely swollen. This air is trapped between the eyelid and the globe, and you see a slight extension of the process to involve the lateral rectus, which is the most commonly extraocular muscle to be affected by the orbital pseudotumor. Then infection of the lacrimal gland itself may lead to dacryoadenitis, and you can diagnose this both clinically and by the presence of what looks like an abscess within the involved gland. And here you can see diffuse periorbital soft tissue swelling and edema, a swelling of the lacrimal gland with a small marginally enhancing abscess cavity within the affected lacrimal gland. And this is also a good example of lacrimal or dacryoadenitis due to bacterial infection. There is considerable swelling of the lacrimal gland compared to the normal one, and there are multilocular collections of pus showing a thick marginal enhancement with a swelling and edema of the related soft tissues, and you can appreciate also the compression or the impingement on the right globe. Then whenever you are not able to detect an abscess inside the lacrimal gland and the patient is presenting by an inflammatory symptoms, then you may think that this may be due to lacrimal gland pseudotumor or adenitis before the formation of an abscess. And the swelling before the formation of an abscess is known as phlegmon, as you know, everywhere in the body before getting liquefied to form an abscess known as inflammatory phlegmon, and this is inflammatory phlegmon of the right lacrimal gland. Then inflammation of the lacrimal system is known as dacryocystitis, and it is the sequelae of stagnation of fluid within the lacrimal sac, resulting in bacterial overgrowth and inflammation. And these are the lacrimal canaliculi leading to the lacrimal sac and the duct draining into the nose. Sometimes you got virulent reflux from the lacrimal sac itself, and the treatment is usually surgical. The imaging findings of lacrimal system inflammation is the presence of what looks like an abscess near the region of the nasolacrimal duct. And you remember from the anatomy, this is the site of the nasolacrimal duct along the inner wall of the orbit, and you see marginal enhancement, and you see soft tissue edema and swelling along the periorbital soft tissues. Then the MRI and the CT findings will include edema of the orbital soft tissues, fluid collection with marginal enhancement denoting the presence of an abscess, orbital and intracranial extensions sometimes may be seen. Then this dacryocystitis being a cystic lesion along the inner wall of the orbit may may be differentiated from periorbital cellulitis, subperiosteal abscess, ethmoidal mucocele, dacryocystocele, which is a cystic swelling that is not yet infected, lymphangioma, dermoid cyst, subperiosteal hematoma, orbital pseudotumor, and rhabdomyosarcoma. This differential diagnosis is according to the literature, but in my opinion, the abscesses, the mucocele, and the dermoid cyst are the major differentiating issues. This is dacryocystitis, classic location, classic appearance. See a multilocular, marginally enhanced lesion along the inner wall of the orbit, medial to the globe, at the characteristic anatomic site of the nasolacrimal duct. And the case may be bilateral sometimes, especially in patients who are more prone for infection, like the diabetic patients. And then here you see bilateral involvement of the lacrimal system on the left and on the right side, with marginally enhancing lesions conforming to the site of the nasolacrimal duct. And this is also another example showing the typical location of the dacryocystitis and the typical appearance with the swelling of the peri and the enhancement of the periorbital soft tissues. Then you know that mucoceles are the sequelae of obstruction of the drainage system of one of the paranasal sinuses, leading to retention of the secretions inside the sinus and consequent progressive enlargement and thinning of the wall of the sinus, then affection of the surrounding structures. The symptoms may include headache, orbital discomfort, decreased vision, and facial pain. And these are the appearance or the CT or the imaging appearances of a mucocele, which is seen here involving the maxillary sinus on the right side. The sinus is expanded, the wall is thinned out all through. There is encroachment on the orbit and encroachment on the nasal fossa, and there is some bulge into the cheek as well. Then the contents of the sinus, which is involved by a mucocele, is usually of fluid density and fluid signal intensity. If you inject contrast material, the lesion will show marginal enhancement, and this is very important to differentiate mucoceles from other lesions that may expand and destroy the sinuses. If you see hyperdensities inside the sinus, which is involved by a mucocele, then you may think of fungal infection that may complicate uh, long-standing retention of the secretions. And on MRI, the mucocele may appear hyper-intense in both T1 and T2 due to the high protein content of the retained secretions. And the treatment of a choice for mucoceles is, of course, the surgery. And here you see bilateral maxillary sinusitis and the frontal or frontoethmoidal mucocele. The sinus is expanded and the wall is rarefied. And also, you may appreciate this marginal enhancement, which is seen also in cases of sinusitis. And this is an anterior ethmoidal mucocele by coronal CT soft and bone window images, and this is axial CT bone window image. You see the lesion which is grossly expanding the ethmoidal sinuses with somewhat encroachment on the orbital cavities bilaterally. And this is the nasoethmoidal mucocele showing bright signal in the T1 and somewhat bright signal in the T2 weighted image due to the contents of the mucocele itself. And invasive sinusitis, you know that we have three types of fungal sinusitis: allergic fungal sinusitis, and the fungal bowl, and the invasive fungal sinusitis, which is known by its destructive capability of the adjacent bony margins. And this invasive fungal sinusitis is commonly seen in immune compromised patients, like those who are diabetics, especially with ketoacidosis, patients with neutropenic, very low white blood count, or patients with organ transplant receiving immunosuppressive drugs, bone marrow transplantation the same, other patients who are receiving chemotherapy, and of course, patients with AIDS. The major diagnostic clue for fungal sinusitis is the presence of hyperdense shadows within the involved sinuses before and after contrast injection. And here you see that the ethmoids are markedly expanded. They contain hyperdense material, and there is some encroachment on the frontal sinus and on the maxillary sinus as well. These hyperdensities are highly suggestive of the presence of fungus, and the presence of destructive changes in the adjacent bony margins is suggestive of invasive type of fungal sinusitis. Patients may present by fever, facial pain, nasal congestion, and sometimes epistaxis. The lesion has the ability to extend into the orbit, may extend intracranially, and may also reach the cavernous sinus. The, the diagnostic clue is made on the presence of hyperdense intrasinus soft tissues, as you can see here in the ethmoidal air cells, and also you can see in the maxillary sinus, which is markedly expanding, denoting the presence of a mucocele as well. And this is an example of extensive invasive fungal sinusitis involving the ethmoidal air cells, the maxillary antra, as well as the sphenoid sinus, with destructive changes in the skull base and also extension into the frontal sinus. The imaging findings of fungal sinusitis include the presence of soft tissue masses of hyperdensity and the CT, relative increased signal in the T1, and very dark signal in the T2. If you inject contrast both in the CT and the MRI, the lesions will enhance. Then the destructive changes in the surrounding bones is suggestive of the invasive type of fungal sinusitis. Then, in spite of the modern management of fungal sinusitis, the mortality remains high, which may reach up to 50 to 80% according to the literature. This is a case of fungal sinusitis involving the maxillary sinus as well as the ethmoidal air cells with intraorbital extension. The complications of fungal sinusitis rays from the ability of invasion of the surroundings. Intraorbital extension, intracranial extension may lead to meningitis, intraaxial granulomas, and epidural abscesses. In vascular invasion, especially the cavernous sinus, may lead to thrombosis, or the dural sinuses may also be thrombosed. The weakening of the arterial wall may lead to myocardic aneurysm, and thrombosis may lead to infarction or hemorrhage due to the dural sinus thrombosis, and also systemic dissemination. In this patient, who is a diabetic patient, presented by diplopia and ophthalmoplegia, the CT scan in the coronal plane showed a mass in the maxillary sinus, and in the right ethmoidal air cells, and this lesion is extending inside the orbit through the destructive changes of the medial orbital wall. And this lesion was confirmed by biopsy to be invasive fungal sinusitis. And coalescent mastoiditis is the inflammation of the mastoid air cells whenever it involves the bone. And at that time, the mastoiditis is known as coalescent mastoiditis. It will affect the outer wall of the mastoid, leading to the formation of very of uh, retroauricular inflammation, and also involvement of the medial wall of the mastoid may lead to intracranial extension of the inflammatory process. Then, whenever the inflammation extends towards the brain, it may lead to epidural abscesses, may lead to vitreous epicytis or apical vitositis. Inflammation of the Gisserian ganglion may lead to cranial nerve pulses. Then thrombophlebitis commonly involves the sigmoid sinus and the internal jugular vein, which are very close to the mastoid. And this thrombophlebitis may be complicated by subdural emphysema, which is considered as a surgical emergency. And this is an example of coalescent mastoiditis. You see that the mastoid air cells are obliterated by secretions, and there is rarefaction of the outer wall of the mastoid. Also, there is erosion of the inner wall of the mastoid, with consequent extension of the inflammatory process in the posterior fossa, leading to an epidural empyema, and also extension of the inflammatory process subcutaneously, leading to the formation of abscess and edema and swelling of the related soft tissues. Another example of coalescent mastoiditis with erosion of the outer mastoid wall and the formation of post-auricular abscess, and you see in the soft tissue window the fluid collection with marginal enhancement. Third case of coalescent mastoiditis with there is erosion of the outer wall of the mastoid with extension of the inflammatory process subcutaneously, and you see the soft tissue swelling, you see the collection of pus, which is marginally enhanced. Then scrofula is the term which is given to inflammation of the cervical lymph nodes, which whether it is of tuberculous etiology or non-tuberculous etiology. But in many cases, we see that TB is the underlying cause of cervical lymph node inflammation. But scrofula is inflammation of the cervical lymph nodes. And you see here, there is multiple enlargement of the cervical lymph nodes seen in the submental area and around the submandibular salivary gland. This is the gland and this is the node. And deep to the sternomastoid muscle, the deep cervical lymph nodes. Actually, the lymphadenopathy, if not treated, may extend into the surrounding soft tissues. It may lead to fistulas formation with the skin or with the neighboring structures. The, uh, the behavior of lymphadenitis depends mainly on the immune status of the patient, and the complications are commonly seen in patients who are immune compromised. Then the ultrasound, fine needle aspiration is the best way to confirm the diagnosis and also to have samples for culture to see which organism you are dealing with. Then you know that TB lymphadenitis is one of the, at least in my country, one of the common causes of cervical lymphadenitis. And the affected nodes may pass into three stages. The first stage is the acute phase, where the nodes are enlarged, but they show homogeneous density and homogeneous enhancement. The second phase, which is commonly seen in the clinical practice, is the subacute phase, where there is central necrosis and enhancing rim. Then the chronic phase, where the nodes are fibrotic and show matrix calcification. This is commonly seen after treatment. Then the lymph nodes due to TB may be amalgamated, forming what looks like a phlegmon or a big abscess cavity containing caseous material. Why you say that these are lymph nodes? Because they are at the anatomic site of lymph nodes. And you see this is the sternomastoid muscle. Deep to the sternomastoid muscle is a common anatomic site for lymph nodes. Then whenever you see a lesion at the anatomic site of the lymph node, you should say first it is of lymph node origin. And this is an example of TB cervical lymphadenitis, two lymph nodes deep to the sternomastoid muscle, multiple smaller lymph nodes deep to the sternomastoid muscle. They are, according to the literature, in the subacute phase with central caseation or necrosis and marginal enhancement. And this chest X-ray shows some broadening of the superior mediastinum. The CT scan showed some of the necrotic nodes at the root of the neck with amalgamation and the central liquefaction forming a large abscess cavity subcutaneously. And this is an example of a TB cervical lymphadenitis with amalgamated the cervical lymph nodes that are matted and centrally liquefied, leading to the formation of what looks like an abscesses at the anatomic site of lymph nodes deep to the sternomastoid muscle. And you see many nodes that are adherent to each other and they are centrally necrotic. And this is an example of tuberculous lymphadenitis. You see bilateral involvement on the left side, a lesion which is small, on the right side, multiple lesions that are relatively larger. And in this patient, you see lymph nodes that are in the acute phase, they are homogeneously enhanced without areas of breakdown. And you see nodes that are in the subacute phase showing central necrosis with marginal enhancement. Then thyroid inflammatory lesions have been discussed in the topic of imaging of the thyroid and parathyroid gland. And you remember that the imaging findings in all types of thyroid inflammation are non-specific. These are the the findings may lead to maybe in the form of enlargement of the gland or enlargement of the affected lobe with heterogeneous enhancement, and this is seen in many of the lesions that can affect the thyroid gland. The organisms include the strep and staph, the fungus, the TB. Sometimes there is a history of trauma or irradiation. There may be fever and dysphagia, and also you may palpate an abscess in the region of the thyroid gland. You know that the thyroid gland is very resistant to infection because of the iodine content, which is one of the major disinfectants used in surgery. Then infection of the thyroid account for about zero point 0.1 to zero point 0.7 of all uh, thyroiditis. Acute infection is in this range, and the high amount of iodine as well as the high vascularity and the lymphatic drainage are barriers against the infection of the thyroid gland. And many times of infection of the thyroid gland may occur on top of a pre-existing disease like Hashimoto thyroiditis or even the thyroid cancer. Then one of the well-known causes of thyroid infection, especially in children, is the presence of a fistulous tract from the piriform sinus leading to the site of the thyroid gland, and this is commonly associated with a branchial arch anomaly, especially the third or the fourth one. And here is a good example, and you see by oral contrast, you see the fistulous tract leading from the piriform sinus to the thyroid gland, and here the thyroid is relatively swollen, and see this air loculus, which is suggestive of inflammation. Then, as I have said, thyroid inflammatory changes or acute thyroiditis has no specific imaging criteria. They see enlargement of the thyroid lobe, heterogeneous enhancement. You may see an abscess inside the affected thyroid, and of course, the fine needle aspiration guided by ultrasound is one of the major tools to confirm the diagnosis and to get samples for culture. And finally, we have some words about necrotizing fasciitis, which is a progressive and often fatal infection of the soft tissues of the neck with a considerably high mortality rate ranging from 25 to 75%. And this disease affects the soft tissues and the deep fascia, and the fascia deep to the skin, but the superficial to the muscles. I mean, the infection is usually in the subcutaneous area. This disease has in a prevalence, of course, in immunocompromised patients, and it may occur after trauma or after or secondary to the presence of foreign bodies may be retained during surgery, for example. Then there are two main causes for this necrotizing fasciitis. Either you are dealing with a single organism, which is a group of group A streptococci known as the flesh-eating bacteria, or multiple organisms, both aerobic and anaerobic organisms are contributing to this inflammatory aggressive process. The diagnosis depends on the presence of air in the involved soft tissues, and the detection of air may not be feasible by plain X-ray, but whenever you have the CT scan, you are able to see this extensive inflammatory process with the development of air loculi within the inflamed soft tissues. You see the obliterated facial planes and many air loculi subcutaneously and in the deep fascia. Then the CT and the MRI of the necrotizing fasciitis can show gas and fluid collections within the deep fascia, diffuse post-contrast enhancement secondary to inflammation, high signal intensity compatible with intramuscular hemorrhage, which may be one of the findings, hemorrhagic areas, and asymmetrical facial thickening, like as you can see here, muscular and intermuscular septal edema with obliteration of the fat planes between the muscles, and fluid collections, uh, uh, which may be due to abscesses in the involved area. And here you see huge soft tissue swelling along the anterior aspect of the alveolar margin. You see the air loculi spreading between the facial planes. You see the diffuse subcutaneous swelling superficial to the masseter muscle, especially on the right side. And this patient is an old patient with decompensated liver cirrhosis, presented by fever and extensive upper lip, tongue, and right neck swelling. And this is also an example of necrotizing fasciitis with air loculi in the deep tissue planes, in the deep facial planes. And you may appreciate the presence of collections which are somewhat marginally enhanced. In the course of this disease, you may got thrombosis of the internal jugular vein, and you may have also extension of this inflammatory process into the mediastinum, causing mediastinitis, as you can see in this particular example. Thank you very much. Alhamdulillah Rabbil Alameen.